And I thought, we don't need necessarily huge technology. We just need human ingenuity. And so that is the patient quality and safety more recent stimulation for me, motivator for me, because we're smart enough to solve a lot of these problems, or at least tackle them.
Professor Jeffrey Braithwaite is a leading health service and systems researcher with an international reputation for his work investigating and contributing to systems improvement. He has considerable experience in researching the culture and structure of acute settings, leadership, management and change in health sector organisations, quality and safety in healthcare, accreditation and surveying processes in international context, and the restructuring of health services. He's known for bringing management and leadership concepts and evidence into the clinical arena, and he has published extensively. My name is Juanita Guidera, and it's a privilege to welcome you here to our Walk and Talk Improvement podcast. Thank you for joining us.
It's a pleasure to be here, Juanita. Thank you for inviting me.
I wanted to start off just to find out a little bit about you. I've had the privilege to meet you on a number of occasions, and every time I've done so, you've struck me as someone that's really dynamic. There's an incredible energy there, and it never stops. You're involved in so many different things, and I wanted to ask you, where does your passion for this work come from?
So I guess your career, it's a great question, by the way. I guess your career can take a number of turns, kind of. This is the case for each of us. But when you find your place, it's easy to have passion. I guess I've found my place, which is doing research and teaching and contributing to the care of patients. Not that I care for patients personally, but I do the research, or try and do much of the research, and try and influence policy and practice so that it's evidence-based. So once you think about it that way, and I'm sure many of the listeners to this podcast will absolutely get that.
Yes.
You know, there's that meme that I've never done a day's work in my life. So if I am passionate, and if I am still on board after quite a number of decades with this kind of work, that's the reason. We've got the patient at the sharp end of us, and we're trying to make care better for patients. What could be more motivating than that?
Okay. I love that answer, that sort of sense of flow. You can visualize it. I suppose just thinking of that research that you've done, if I was to ask you over the course of your career, you've looked at patient safety, you've looked at quality in multiple different guises. Are there significant themes or things that you would say are absolutely fundamental or that come up time and time again that you would say are central to a culture of quality and patient safety?
Yeah, it's always struck me that healthcare is simultaneously high tech and high touch.
Yes.
To keep patients safe, to improve quality, to make the system better, you need a lot of technology. You need not just laptops and stethoscopes and scalpels, but you need beds and tables and chairs, and you need waiting rooms, and you need electronic medical records, and you need diagnostic equipment and test equipment. So that's all high tech. And we tend to think, let's do more of that, and we'll keep patients safer. Healthcare is about people who provide the care to the other people who receive the care, and hopefully it's a co-production. It's a dialogue between the two about what care is optimal for that patient or that group of patients. So I've really learned that. It doesn't, in a way, when I say it that way, it doesn't sound that profound. If we can get the sweet spot of technology and people and their motivation, that's the secret, not so secret sauce.
Yeah. In any of your research, is there anything we can do to prevent people getting distracted or overwhelmed or overburdened by the technology and forgetting that high touch element of it?
So I was just talking yesterday to the National Academy of Medicine, the group in the US that produced the famous study that listeners will know, To Err is Human, 25 years ago. The theme that sticks out is I was talking to them about 60, 30, 10. The profile of the health system, modern health systems like the Irish health system, the US, Australia's health system, where I live, is 60% of care is in line with level 1 evidence or consensus-based guidelines. The guidelines the clinicians say should deliver the care, by which care should be delivered. 30% in a modern health system is some form of waste, where we deliver low-value care, or we do a test and no one reads it, no one reads the results.
Yes.
And 10% is harm, although we now think from recent studies that harm is higher than that.
Quite significant.
Yeah, it is significant, and it's a great concern. So luckily, every clinician knows this. Every clinician knows that care is mediated by technology, but not delivered. So the technology needs to be in support of the care that's being delivered by people on wards, in general practice, on the front lines of care, and not to have the technological imperative overtake that. So test results, for example, have to be interpreted and discussed with a patient rather than, let's say, the technology rules the roost. So it's finding the sweet spot. Now, that really is important because people need to be motivated to think that they're contributing to the care of their patients. And that's helpful in not burning out. The problem with motivation of the workforce and burnout is there's too many patients almost. Now, that's crazy to say because that's what we're there for. But the overwhelming thing that clinicians on the front lines report is it's just like we're so busy. There's not enough time sometimes to do the care we would like to deliver. Now, technology can help because it can make things more efficient. An electronic medical record, for example, an electronic health record helps because you don't have to repeat the documentation a million times. However, it also can hinder. It can mean that you have to do more things in service of the IT or the technology.
The machine.
Yeah. So the answer is as simple and as profound as we have to find the sweet spot between having enough people on the front lines delivering care, simultaneously improving the system as they go along, and not being overwhelmed. Now, some people have started to talk about quality and safety clutter. So let's say you and I were on the front lines of care delivering care. We're on the front lines at the sharp end of the system. We're clinicians on a ward, in a general practice, in a theatre, making care as good as we can, helping to create good care for patients in a dialogue with the patients, co-production. But let's say we also have to complete checklist, service the IT system, document all the stuff that happens, obey all the policies in place, and there's 2,000 of them in place, and then there's 6 guidelines for this particular patient. Which one do we choose? And suddenly we're overwhelmed by the documentation. We're overwhelmed by what's come to be called safety clutter, asking too much of the people on the front lines to do too much documentation. So somewhere, and we're doing a whole series of work on this, somewhere we have to reduce the clutter while keeping patients safe. Now, one argument is we don't have as many requirements as people to document, do checklists, fill stuff in, giving them more degrees of freedom to deliver the great care that we know most people deliver.
A need.
So where's the... Exactly.
Yeah. And I'm struck by that. And in particular, you talked about the 60-30-10 a minute ago, and that 30% in the middle. Like, how do you determine, actually, I don't need to do that test. I don't need to pursue that. I don't need to follow up on that it's safe to do it? Because I think one of the challenges is that culture of being risk adverse and wanting to make sure that we've closed out every single possible end that we can because it's available to us. How do you manage that?
Sure. So one thing is to pick up what I was just saying about safety, trying to remove the burden of bureaucracy, for example, on patients. Trying to do the right thing first with no harm, and then we don't have to redo it. Every clinician knows in their particular area, whether it's they're treating renal patients or they're in operating theatres as a surgeon or a nurse on a ward, they know there's more bureaucracy than they care to have, and that we can find a way to cut through that, delivering more time to spend with patients. So 60% in modern health systems, high-income health systems like the Irish health system and the Australian health system and the US and the UK, 60% is care that's in line with level 1 evidence or the guidelines. These are big epidemiological studies where we've looked right across whole health systems. And we've done enough of them to know that on average, about 60% of care is in line with evidence. However, it differs by condition. Some conditions get more evidence-based care than others, and it differs by setting. So some hospitals or practices are more likely to deliver evidence-based, guideline-based care. So, for example, very highly skilled specialists, you could imagine that they would deliver less evidence-based care because they're so specialist. They know what to do when they deliver care. It's actually the reverse. If you're much more likely to get care that's in line with level 1 evidence or the guidelines, They actually help write the guidelines often, and then they follow the guidelines. Other people who are less senior in their career or do more general work and are not super specialized are less likely to deliver evidence-based care. We've been working with general practitioners in Australia, for example, to say, how can we get more evidence-based care, given that they have to deal with the full spectrum of almost every condition that ever comes in?
Yes.
Part electronic, part of that's like, can we get up-to-date data in front of them? Because the other bit about evidence is, it's very interesting. It takes about 17 years for only 14% of evidence ever to enter practice.
Yeah. And that I find absolutely fascinating. As you talked about there, like you have the specialist who's potentially written it or has researched it and they can access it straight away. How do you get it in front of people? So, you think of a normal acute hospital setting. How do we change that? How do we lessen that time? Because the data will have changed so considerably in years again that it'll be obsolete.
A lot of people working on that across the world, including people in Ireland, okay? So the question is, how do you skill a workforce that's under pressure all the time with just normal care to be delivered right now today
Yes.
with the most up-to-date evidence and 11 systematic reviews published every day? So wherever you are, whatever your specialty is, whatever your expertise area is in healthcare, you're behind in your reading today.
And will be.
So yes,
Permanently.
it's the dog, Juanita, chasing the tail.
Yeah.
So how do we do that? Well, we think electronifying and AIifying is going to help us. So I don't know if you go onto your large language model on your app on your phone called ChatGPT or Gemini or one of those, Copilot. And if you have some symptoms or you have something goes wrong and you've got to go and see a GP, you might ask that AI in your pocket, the whole of the web in your pocket. You might put the symptoms in and say, what do you think I've got? And then you go to the doctor. Well, have a think about at the other end of that telescope. What do you think the doctor's doing? They're using AI as well. It takes 17 years for only 14% of evidence ever to get into practice. But there's a problem. And you know what the problem is? The AI can have a delusion.
Yes.
I've seen it happen. So as it becomes more refined, or as we get more specialist AI, which actually has the medical database and make hallucinations, we will get more refined data in our pocket to help with that dialogue between patient and clinician. That's going to be very useful. We think that will narrow the evidence gap.
It will. I think it'll make a huge difference if you had a specific AI system just for clinicians with the medical data that you could trust.
Don't forget the doctor's still important, or the nurse, or the allied health professional, because they've got the skills to interpret what the data means. And they've got the skills to then put you on a course of treatment. You don't have that. So we should resist the temptation to think just because we've got data at our fingertips as consumers that we're suddenly an expert.
Yeah. And I wonder how much of that actually fuels that 30% of unnecessary tests, because somebody has looked it up and said, can you test for this? I have this symptom and my AI, or my chat GPT has told me that I have this, and how much of it comes back to that? That's really fascinating. There was something else that struck me as you were speaking there, that quality and safety clutter. Is there a minimum data set internationally that you would say is evidence-based that says this is the minimum data set that you need to capture on a patient to provide you with enough information about early warning scores or risk of sepsis? Or is there a standard data set that's agreed at the moment, or is that something in development?
It's in development. The problem with medicine and healthcare is, look, there's 10,000 ICD codes to describe all the symptoms and things that can go wrong, the diagnoses, characteristics. If you just take rare diseases, there's 7,000 rare diseases. So it happens, rare diseases aren't that rare.
No.
They've just got one of the 7,000, so that's why it's rare. But actually having a rare disease is quite common. So let alone all the normal stuff that can go wrong, like arthritis, or you get heart disease as you get older, or whatever, a bit of cognitive impairment. All of those things, they're broad-based diagnoses, right? So having one data set that's going to sort all that out for us, that's not going to happen.
No, too complex.
Yeah, too complex. Patients are complex. The health system's complex. Clinical care is complex. We've got degrees of complexity all over the place with healthcare. There's no one big data set that's going to solve that.
Which brings me nicely to my next question. So I wanted to talk to you about the complex adaptive systems. And in particular, I suppose I'm thinking at the moment within the healthcare system in Ireland, we're looking at that whole area of integrated care. And I know that you've done work on a boundaryless hospital. It was something that you'd looked at previously. Could you tell us a little bit about that and maybe any key learnings that you'd like to impart for people that are interested in integrated care and how we can achieve that here?
Okay, so this is a great question. Well, let's think about the ingredients in a health system, okay? You've got primary care and community care. You've got acute care. You've got rehab. You've got aged care. And then you can subdivide all those up.
Yes.
So even at the level of the structure of the health system, it's complex.
Yeah.
All the interactions going on to deliver care with the policymakers, the leaders and managers, the different kinds of ologists and clinicians, trying to work across those boundaries to
Yes.
integrate care so that the patient has a trajectory through the health system, regardless of what they've got, and they don't fall through the cracks. So it's not just Ireland, everyone's working on that. 25 or 30 years ago, the health system is so complex that we need the skills to be able to navigate through it to get to the other side. So that's called integrated care. It's joining up all the bits, all the dots to make sure care is seamless, not just for the provider, but for the patient. Now, that is a formidable task. So it's always a work in progress. There's no magic wand here. Hey, let's have an integrated health system. It requires people working at the boundaries. That's why I wrote that paper years and years ago, 2.5 decades ago, called The Boundaries Hospital. It requires people who are conscious of working at the boundaries so that the transitions of patients are good. They've got medical reconciliation, for example, across the boundaries. So if they leave the acute sector to go into the aged care sector, we've mapped and followed them through, and there's a continuity about their care. For example, in Australia, I have an app now, which is my health record. And every time I have a procedure or go to a GP, that gets loaded onto the app and I can see my history, but I can also share it with my practitioner. So
Yeah.
it puts a level of me in the box seat as a consumer, not an expert researcher, but as a consumer. So I think those kind of enablers of IT plus people working at the boundary who are conscious of where the patient's going from and to, and help with the transitions, that's going to help with integrated care. And I'm looking forward to Ireland making great strides in that area.
Yeah. We've introduced the Health HSE app recently, and it does make a difference. I think we're not maybe at the level of all of our hospital appointments just yet, but it's coming. It's coming, and I think that that's a positive. The concept of that complex adaptive system and complexity science, when we think of quality and patient safety or quality improvement has been around for a very long time. And we're seeing the advent of things like implementation science and human factors and complexity science and all of these different things. Do you think quality improvement stands alone anymore, or do we need to be taking all of those other things into consideration when we're looking at improvement work?
That's very good. Let me try and address that. That's a tough question. So a lot of your listeners are going to be quality improvement people, patient safety officers, quality improvement officers, or they interface with those people a lot while they do their work and they rely on their expertise. So what's happened with quality is at first, in the old days, like 30 years ago when the quality movement was embryonic, people were saying, okay, we've got to get together. We maybe have a quality circle, a group of people who are interested in thinking about their patients and then saying, how do we improve the quality of care? Very low tech, very dialogue based. Now there's all these new concepts. So it's easy to get overwhelmed. So it's not just quality, it's like safety, 60, 30, 10, 14 years to 17, implementation science, the consolidated framework for implementation research, the theoretical domains framework. Okay.
Yeah.
So suddenly we've seen an explosion in what we can have recourse to, the tools we can use, the frameworks, the ideas in quality. So quality really, in a sense, has become professionalized. If you look on your computer, you've got drop-down menu, file, all different menu items. That's almost what we've got now with quality and safety. We've got a whole lot of drop-down tools that we can use depending on the circumstances. Do we need a framework? Do we need just some dialogue? The problem is, in a complex system, we're forever navigating through the system trying to cut through all the complexity. And that's the key, I think, headwind that we're facing.
Yeah. And I love that. And for me, for most people working in systems, you need to be able to access whatever tool is going to support you best on the day. It's not a case of saying, I'm only going to use one methodology. And on that, are there any other frameworks that you would have said you would find really supportive or complementary to the quality improvement work?
So I always think what we need to do is be focused on what is the problem we're trying to solve in this particular instance, and then work backwards. A lot of people learn a tool like the Consolidated Framework for Implementation Research, or the Theoretical Domains Framework, or Proctor's tool. And then they use that when they come across an issue that they're trying to tackle. Oh, they learn how to do root cause analysis, so let's do more of those. Stop and think first. What is the problem that we're encountering, and what's a good solution? The other thing I want to raise, and I think your question leads me to this, is safety 1 and safety 2.
Yes.
So one of the things we've done is really looked at this whole idea of how do you keep patients safe? And the immediate response most people is, well, we've got now checklists in place, and we've got policies, and we've got IT to support us. But all of that is designed to try and reduce the number of adverse events, hopefully to get to zero. Although in a system this complex, way too stretch a goal to think we'd have zero harm. However, if all we're doing is trying to reduce harm all the time, then what we're not attending to is the fact that most care delivered by the Irish health system does not have harm.
Yes.
In a system this complex, how come so much care goes right? If it's 10% harm, 90% of care does not have an adverse event and is pretty darn good care. So how can we understand that, and how can we do more of it? Am I allowed, Juanita, to use a couple of metaphors?
Absolutely. Love a good metaphor.
So say I was a researcher not of patient safety and quality. Say I was a researcher of marriage.
Okay.
But all I ever investigated was divorce. I wouldn't know what a happy marriage was.
Yes.
So safety's a bit like that. We keep investigating when things go wrong, the divorce, the things that harm patients, and we haven't investigated sufficiently when things go right. We know more about error and less about when things are kept safe. And we edited 6 books on this. Now, I'm sure your listeners won't have read all my 6 books. I'm not expecting them to. But what I'm trying to say is there's a lot of information about safety too. And I think we need to not always be seduced into looking at harm. Of course we should. But we need also to look at how come things went right so often. So say when you're doing an RCA, a root cause analysis,
Yes.
I'd encourage people to certainly deal with the problem that stimulated the RCA. But in addition to ask a question, before the RCA got triggered, the event that caused the RCA to come into existence, how come we did this right so frequently? And what were the circumstances that created that? My second analogy is a lot of your listeners, because I know a lot of Irish people, have been to Australia. And just occasionally, you get a shark alarm. And there's these big white pointer sharks that, every year or so, they take a human and bite their surfboard and bite their leg off or even kill them. And it's tragic.
Mm-hmm.
So if I was a researcher of shark behavior and all I investigated was when sharks attacked humans, that's an abnormal event. I wouldn't know about shark behavior in the ocean.
Yes.
So happy marriage versus divorce and a shark biting a human versus shark behavior, there's far more to learn about normal shark behavior and a happy marriage. And that's the analogy with patient safety, safety 1 and safety 2. A bigger and bigger database of failures tells you more about failures.
Yeah. And there is an increasing body of evidence around things like the impact of retention, psychological safety, teamwork, all of those different things that we know are fundamental to quality and patient safety, and we know that they have an impact. What is it about human nature that makes us look to the safety 1? What is it makes us sort of focus on that one thing that we got wrong? In a lot of instances, obviously, it's a serious incident or a major harm or adverse event has happened. But what is it that sort of says, actually, stop, focus more on those things that we know actually work? What draws us back to it time and time again?
Well, humans are problem solving. And if we're on the African savannah, we were looking for the lion coming over the hill, not just skipping through the butterflies and the tall
Yes.
grass having our time. Okay. We're designed, Homo sapiens is designed to look out for problems.
Mm.
Safety too says, sure, keep doing that. You've got to attend to adverse events. If someone is harmed, even if it's a little bit of harm, they deserve our attention.
Absolutely.
But what we're saying with safety two is, sure, do all that. We're not going to stop you or argue that you shouldn't do safety one. But what we're saying is, do you want to really understand the system which produces good care all the time? Have a look at when things go right a bit more frequently than we do. What you're really doing then is you raised, it's a complex adaptive system. You're really understanding the complex adaptive system when it's working well. Can we understand that better? What are the characteristics that create good care? Can we do more of that?
Yeah. And one of the things that we're doing at the moment here in Ireland is developing quality coaches. So supporting people to develop the skills to coach others in quality improvement, and that they can do that within their area of work, very close to where they can see what's happening and see where the need is. Is there advice that you would have for quality coaches based on your knowledge of the system and experience in terms of the research and things that you've seen?
This is a great idea. Look, everybody needs a mentor.
Yes.
Sometimes we don't get a mentor, we get a tormentor, and we have a bad one, okay? Everyone needs a mentor or multiple mentors. Life is too complicated for you and complex for you to just make your way in your career without help.
Yes.
If there's one thing I've learned about healthcare, it's a team game. It looks like it's an individual game. You go to your doctor. It's a team game. Behind the doctor is all this other sort of stuff. So coaches are fantastic. In fact, Atal Gawande wrote this brilliant paper. I think it was in New Yorker or the New York Times or somewhere. And he posed this question. He said, I played tennis a couple of nights a week. And I've occasionally had a tennis coach to help me get better. I manage my own superannuation pension, my share portfolio. I've got a financial advisor, a coach to coach me with my finances. But as a surgeon, I go into the theatre. There's no coach. I'm the top dog and I just deliver care. How come? Surely doing surgery is much more important than your share portfolio or learning to play tennis. And the very important thing of delivering surgery does not have a coach. So he got a close to retired surgeon in his discipline to come into theatre, watch what he was doing, watch how he was doing that procedure, and then gave him constructive feedback. That, I think, was actually the paper that turned my head round and said, quality coaches, mentors are extremely important. It endorses this idea in Ireland that you're going to have coaches for people, but I think there's an imperative for the person themselves, the clinician on the front lines, even the policymaker and leader and manager, to go and get a mentor or two and just talk through sometimes when you're having good times and bad times. When you're doing good stuff, you want some feedback on that. When you go through a difficult time, get some help.
Yeah. In terms of your own interest and the research that you're doing at the moment, is there anything that really fascinates you? Any question that you would say, there isn't an answer to that yet? I really want to find out what that is.
So I've been working in the last 5 years, of course, on quality and safety. I'll never leave that because that's so dear to my heart, as you can hear. But I've been starting to think about 5 years ago, we really need to think more thoroughly about climate change as a safety and quality problem. So it matters probably a lot in a country like Australia, where we have these huge, you read about it every winter time, your time, summertime, our time, where there's this huge wildfire and there's all this particulate matter thrown into the atmosphere. Anyone with COPD or asthma gets a respiratory problem, they all descend on the health system. Or vector-borne diseases change pattern. Areas where we never experienced this kind of mosquito-borne disease are now experiencing it. There's all sorts of things, droughts, floods happening that are accelerated by climate change. So that all poses new threats or accelerated threats on the populations we're trying to serve, keep safe, and give high-quality care to. Or the health systems that need to be sturdy and robust and future-proofed, because they'll come under pressure. And if the generator goes out or the electricity grid goes down, you've got to provide care at the very time when you can't provide it very well. So I started to think about climate change. We've published a couple of systematic reviews, one on what do you have to do to decarbonize and what do you have to do to adapt to a changing world. So let me give your listeners a couple of facts. Join up all the healthcare in the world. If it was a country, it would be the 5th biggest emitter of greenhouse gases. Healthcare produces more greenhouse gases than aviation and shipping combined. We don't think about healthcare as this massive creator of greenhouse gases, but it is. We're going to have to deliver usual care, but we're going to be under more pressure from climate change-induced patient care, depending on which country we're in and what our environment is. But we're also going to have to get to net zero by 2050 because we've all signed up to the Paris Agreement. And not just decarbonize, but adapt to this changing world, because we're not going to meet the 1.5 degrees above that the UN would like us to as a world.
Yes.
So we're going to have more climate-induced patients, more potential harm to patients, more potential quality improvement headaches, at the same time as we're having to decarbonize and mitigate our own greenhouse gases, our own carbon footprint, and get to net zero carbon. So that's going to be a pretty tough task for healthcare. So
Yeah.
I've started to address that as a quality and safety issue. And if readers want to contact me, if listeners want to contact me and can't find those systematic reviews, we've published one systematic review in Nature Climate Change, a big journal, and another one in the BMJ, British Medical Journal, on these twin problems of how do we decarbonize while at the same time adapt to a changing world.
Mm-hmm.
And we're going to have to walk and chew gum, as I say.
Yeah. I listened to something that you did a long time ago, and you asked the question, how can we survive our own cleverness? It struck me in the context of this work. Have you thoughts on that since you said that?
Yeah. So that was a TED Talk. If people haven't had enough of me and they want to listen to my TED Talk from about 10
Highly
years ago,
recommend.
it's on my website. And the question there was, humans are ingenious. We've created this world, which has got all these fantastic features. Many of us have good careers, satisfying jobs. We've got the built environment. Look, I just come to Ireland and see all the magnificent buildings in Dublin as I walk or have a run down the Liffey. I think what a fantastic society has been created by Irish. But are we too clever for our own good? Because we've also created climate change. We've also contributed to pandemics because we haven't done a good job sometimes of handling COVID-19. And we've created nuclear weapons, which could wipe us out at the touch of a button. So we've created this world that's fantastic for many of us. Not everyone, because there's a whole lot of people who don't have what we have in the high-income countries. But we've created this fantastic world which is full of promise and potential and is great for many people. But we've also created the conditions where we can wipe ourselves out.
Yeah.
So how do we avoid that and maximize everyone's opportunity that
Yes.
we in high-income countries have?
Yeah, and it is. And I think it's changing. Even the conversation that we had about AI, the impact on water supplies, electricity, and so on, asking AI random questions is phenomenal. And we don't measure that. We don't have any sense of that as users of it. And also, the other thing that strikes me, and you touched on it there in terms of climate change, is being able to deliver care where we don't have access to electricity, or there has been a flood, or there's been a major storm and we can't. And we've seen changing climate conditions in Ireland in recent years. So I think it's going to touch all of our lives. Is there anything, I suppose, that you would say has been a personal inspiration to you, or a book or a poem or something that you take with you in your work that grounds you or keeps you focused on this passion that you have?
I remember reading, and it's a movie as well, Ken Kesey's One Flew Over the Cuckoo's Nest.
Oh, yeah.
It's a fantastic book. Great movie with Jack Nicholson. And it was really about the poor, inhumane care that psychiatric patients got from the health system. Now it's a drama, it's a novel, but it struck me and really motivated me because we can't treat patients like that. Now, this was an exaggeration because it was a drama, but we can't treat patients, whether they're psychiatric patients, mental health patients, or patients who come to us for normal care. And that really spurred me on to say we have to do better at being humane as a partner to the high tech that we started with, okay? The second thing is, a couple of times ago when I went to Dublin, I went to Newgrange. You've been to Newgrange, haven't you?
I have. It's beautiful. It's an incredible, for anybody that hasn't been there, I would recommend that if you can at all, It's phenomenal. The architecture, the work that went into building it so many years ago without the technology that we have today, it's phenomenal to try figure it out and understand it. Yeah, it's beautiful.
So that was my point, but I wanted to make a different point about New Grange.
Mm.
So New Grange obviously is an ancient monument, and the architecture from the ancient people who built it is just remarkable. And it has this, at the summer solstice, I think the light comes in.
It does.
Just correct. And, you wonder, how did they do that? With no technology, stone technology. I think it's older than Stonehenge or something.
And pyramids.
Yeah. So I went there and experienced that, and I was just struck. And the guide said, this is all overlapping stones above us that has no cement or mortar or lime. It's got no stuff to keep the stones together. It's just overlapping stones. And the guide said to me, it's probably the only roof in Ireland that hasn't had a leak, which was fantastic. That was just, there was no water on the floor, And I thought, we don't need necessarily huge technology. We just need human ingenuity. And so that is the patient quality and safety more recent stimulation for me, motivator for me, because we're smart enough to solve a lot of these problems, or at least tackle them. And so Ken Kesey's One Flew Over the Cuckoo's Nest, treating people kindly and appropriately. And then New Grange, we don't need digital high tech necessarily. We just need good motivation and the smarts that people are endowed with. So maybe that's a good place, Juanita, to finish.
I think that's beautiful. And Jeffrey, thank you so much for your time.
It's always a pleasure, Juanita.
And as we come to the end of this episode of the Walk and Talk Improvement Podcast, we'd like to thank Jeffrey for sharing his wisdom and experience so willingly. It's been such a privilege to speak with him on this topic, and topics, I should say, because we've covered a lot of ground today. And for you as a listener, we hope that Jeffrey's insights will continue to inspire you in your work to improve health and social care services. We hope you enjoyed this episode, and if you'd like to hear more content like this, you can listen to the Walk and Talk Improvement Podcast wherever you get your podcasts. Thank you for listening.